with our Zoom webinars and meetings. All right, you're good to go? Okay, excellent. Well, I just want to say good morning for those of you in the Bay Area, maybe good afternoon for anyone joining us outside of the Bay Area. Welcome to the Down Syndrome Connection of the Bay Area's webinar series. We're going to be focusing on the needs of individuals with co-occurring Down syndrome and autism, along with families, caregivers, educators, and medical professionals interested in learning more about DS-ASD. My name is Elizabeth Lewis. I am the Director of Education at the Down Syndrome Connection of the Bay Area. And on behalf of DSCBA, we want to welcome you and thank you for taking the time to join us. Today's webinar is the dual diagnosis of Down syndrome and autism. Our panel of speakers today, we have our Dr. Noemi Spinazzi. Dr. Spinazzi is a physician at UCSF Benioff Children's Hospital in Oakland, attending physician, primary care, medical director of Down Syndrome Clinic, Charlie's Clinic, director, Developmental and Behavioral Pediatrics resident rotation, and assistant clinical professor at UCSF School of Medicine. She will be doing part one of this webinar. And then we also have Teresa Unnerstall. She is on the DSCBA staff, serving as the Down Syndrome Autism Consultant. Teresa is also the author of, and I see your book is in the background there, a new course, A Mother's Journey, Navigating Down Syndrome and Autism. We're going to be monitoring questions. So you guys will see the Q&A option here at the bottom of the screen. So if you have any questions, and we would love for you to participate today and let us know what your questions are, we will take pauses along the way when it seems like a good opportunity to do so. And I'm going to be monitoring the questions. So if you have any questions at all, and we are allowing anonymous questions, so please feel free. There's no such thing as a silly question. We appreciate anything you want to say. Questions, feedback, anything you have to offer us. We are here. That's why we're here, to have this discussion. So please feel free to ask anything you want in the Q&A, and I will address those questions with either Dr. Spinazzi or Teresa as we go, when there is time, when we take a pause to address questions. The other thing we'd love for you guys to do is utilizing that Q&A component. If you could please indicate for us whether you are working with, or the parent or caregiver of someone who already does have that dual diagnosis of autism and Down syndrome, or if you're just interested in learning more about the topic. We'd love to know that. If you are working with a child or a person with a dual diagnosis, or you're a parent or a caregiver of a person with a dual diagnosis, if you could also indicate the age of the person, then that would be helpful for us as well, as we gather more information from our members and our participants. So I think that is about it. We've got a 2-hour block here for the webinar, and we're going to give plenty of time to address all of those questions you may have, but we don't expect for it to run for the entire 2 hours, but we do have that time just in case. So with that, I believe we are good to go, and I'm going to turn it over to Dr. Spinazzi. I'm going to stop my video here so we can have all eyes on you. Thank you, Dr. Spinazzi. Thank you, Teresa, and welcome everyone.
For sure. And while we may not go the full 2 hours, you guys know that I like to talk. So buyers beware. Good morning, everybody. Thank you for having me today. I may know some of you, and I may not know some of you. I am here today to talk to you about the dual diagnosis of Down syndrome and autism. Anytime we present at any conferences, we're supposed to talk about any sort of financial disclosures. I have none, but my disclosure is that I love what I do, and I come at this with a passion and a desire to always learn to provide the best care possible for our young friends and patients. Just as to start us off with a background, if you are coming to this wondering, why are we talking about autism? I thought that the two things could happen together. Then you're not alone. Actually, until fairly recently, it was believed that people with Down syndrome could not have autism. And this is just an excerpt from a textbook that was published in the 90s that basically says that, yeah, sometimes we see people with Down syndrome who also have autism, but this is pretty rare and there doesn't seem to be any association. And what I hope to show you by the end of this presentation is that that's not the case, and that's exactly why, as a community of people caring for people with Down syndrome, as well as providers, we need to know that the two can coexist so we can take the best care possible of our patients. The information I'm going to present to you today is not made up on the spot, and it's not just what I see clinically. This also comes from a review of every scientific article that's been published on this topic, as well as a research survey that I did last year along with a couple of colleagues. The literature review actually looked up every article that mentioned both Down syndrome and autism. It was done by two doctorates, a researcher, a PhD, and a doctor of psychology, who looked at all of these articles that were about 107, and out of those, they found 37 that were actually relevant, then read all the references to and found a few more for a total of 43 articles that they looked at and reviewed, and then I looked at most of them as well as I was preparing this presentation. Just as a trend with regards to these articles, whenever one does a research study, ideally there would be a comparison group. So we are comparing people with Down syndrome and autism with people who don't who have Down syndrome and don't have autism, for example. And not all of these articles were like that. Some of these articles were simply following people with a dual diagnosis over time. So this is something that we just keep in mind when we think about this research. Also, anytime we're doing any sort of research study, the more people we research and look at, the less likely it is that what we find is due to chance, and the more likely it is that what we find is actually a true statistical correlation. Because this is the dual diagnosis is something that continues to be under-recognized and understudied, some of these studies had a pretty small sample size, and that's another limitation of the research that's out there. Given these disclaimers, however, the results of this literature review did begin to describe what people with a dual diagnosis look like and present as, while also highlighting the need for further research. The research survey that we did at Charlie's Clinic actually used the Down Syndrome Autism Connection, which is an online support group. And we surveyed members of this online support groups, asking them a bunch of questions, including asking them about the early years before their children were diagnosed. We asked them about interactions with both the medical and educational systems. We asked them about the experience in obtaining a diagnosis. We asked them about what interventions helped. And I had help in looking at these results, including my queen, Dr. Elisa Velasco, who did a lot of the work. Dr. Lena Patel is a psychologist from the University of Colorado, who actually just wrote a book on toilet training in people with Down syndrome. And then Drew Woodicke is a master's in public health, who's actually now in medical school. So we took this on as a team. So with that out of the way, explaining to you where this information comes from, let's dive in. First of all, how common is autism in people with Down syndrome? There are a lot of reports out there. Some reports say 4% of people with Down syndrome have autism as well. Others say 40% of people with Down syndrome also have autism as well. So this is a big range, right? And this is because different studies use different tools to decide if someone also has autism. To know if someone has Down syndrome, you can do a blood test, right? To know if someone has autism, it's a little bit trickier, and there's no brain test, blood test, skin test that can tell us. And I'll explain in a little bit how we diagnose autism. But this is why there's such a variation. When there's a lot of variation in the literature, what we do is we use things called meta-analyses that look at all of the articles on a topic to try and come up with a more confined range. And so in 2015, there was such a meta-analysis done that suggested that the likely prevalence of autism in people with Down syndrome is 16%. 16% is about 1 in 8 people. So that's a significant percentage, right? 1 in 8, 1 in 6. I don't know, it's early in the morning. 16% is not rare. And it's much more common than the likelihood of autism in the general population, which is 1.7% or 1 in 54, according to the latest CDC reports. So this is really the opposite of what we used to think in the 80s and the 90s, right? It turns out that autism is actually pretty common in people with Down syndrome. When we think about what are some things that might be associated with having autism, much like autism in people without Down syndrome, autism seems to be more likely in boys in people with Down syndrome. In a number of studies, looking at the prevalence of autism in people with Down syndrome, they found that the majority of their patients with a dual diagnosis were male. But not all studies found this association. And again, remember, many of these studies are small. So I'm not gonna bet in Vegas that these are the real prevalences. However, clinically, I have also seen more boys than girls with a dual diagnosis. There is a bigger thought around this actually in the broader autism research that part of it might be that girls are a little bit more difficult to diagnose. And so it's not just that it's more likely that the chance of having autism is higher for a boy than for a girl, but also that maybe we're missing some of the girls because the girls might present a little bit differently and might be a little harder to diagnose. Is there any medical thing that is associated with a greater chance of having autism? A couple of studies have looked at this, and very little has panned out so far. The one thing that does seem to be associated with an increased chance of developing autism is infantile spasms, which is a specific type of seizure disorder that's developed in early childhood and can look like that startle reflex, that Moro reflex in little clusters. But this is the only thing that's been found so far. One thing I want to tell you is that I am collaborating with an amazing group of doctors from Children's Hospital Boston and the University of Colorado and Children's Hospital Los Angeles and Luris Children in Chicago. And we are looking at a really large group of patients. And one of the questions we're trying to answer is, are there any medical conditions that seem associated with a greater chance of autism? So I'm really hopeful that in the next few years, we're gonna have better answers for this. Does this mean that every kid who had infantile spasms is gonna develop autism? No, it doesn't. It just means that we might keep a closer eye on those children who have that medical history and may have a lower threshold for referring for further evaluation if we have some concerns. Some studies looked at IQ, which is a measure of cognitive function. And what they found is that individuals who had lower IQs were more likely to also have a diagnosis of autism. Is this a chicken or the egg thing? A little bit, because it's also harder to do these types of tests on someone who has autism. These tests were not created for people with a dual diagnosis. Regardless, if someone has a lower IQ and they're showing some behaviors consistent with autism, this might prompt us to do more evaluation. A couple of studies looked at family history. Is there something about family history that can clue us into the chance of the person having autism? Having a family history of intellectual disability, speech or learning disorder, an autism phenotype, as well as having a parent who themselves has autism or a sibling with autism does increase the chance of the child having autism. These were not big studies. Look at how few patients they had in each of these studies. The one on the right didn't have a comparison group. So again, these are just associations. This can tell us that as providers, we should be asking about family history. And it tells us that if there is a strong family history of autism and you're wondering if your kid may have autism, it's worth bringing it up to your doctor. But again, this doesn't mean that having someone with autism in your family means that your child with Down syndrome will also have autism. And again, our big research group is looking into family history as well. So some take-home points about the sort of prevalence and associated factors is that about 16% of people with Down syndrome also have autism. It seems to be more common in males. It may be more likely with some medical things, including infantile spasms. It seems to be associated with lower IQs on testing, and you may find a history of developmental issues when you do a family history. This is where I want to spend quite a bit of time. How do kids with a dual diagnosis present? First of all, we asked in our survey, we asked parents, at what age did you start having some concerns that your kid may have something else going on? And then we asked them, and then at what age were they diagnosed? What we found is that the age at which parents began to have some concerns on average was a little older than 3.5. And that unfortunately there was a long gap between when parents first developed concerns and when the child was eventually diagnosed, a gap of about 4.5 years, which is unacceptable. We asked parents, who did you talk to when you had concerns? Did you talk to family members? Did you talk to your child's teachers or therapists, to your primary care doctor, to your medical specialist? These were open-ended questions, so it wasn't a multiple choice. We just let people answer. What we saw is that at least more than half of our respondents talked to their child's teacher and or therapy provider about their concern, and another half talked to their primary care doctor about it. And unfortunately, 80% of those families that spoke to a teacher, therapist, or primary care doctor found that that person was not knowledgeable about the dual diagnosis, nor did they know where to point them to in terms of next steps. Versus medical specialists like neurologists and developmental doctors who seem to know quite a bit more about the dual diagnosis. Of note, some of our respondents did mention that they spoke with family and they felt that other family members also didn't know a whole lot about a dual diagnosis, which makes sense, you know. I think that the onus is really on us as doctors and teachers to be the ones to direct families in the right direction. What I get out of this is, if you're wondering, might my child have autism? And then you've been reassured by someone who sort of dismissed your concerns, but you're still a little worried, just know that, at least according to what we have found, it's pretty normal for a lot of frontline providers to not know much about this, and that it's okay to dig further if you still have a concern. We asked our parents, what were some things you noticed about your child that made you think that they were a little different from other children with Down syndrome? And this is because at first, a lot of parents might just notice that their kid is just a little different from the other kids at the Down syndrome connection events or at other kids with Down syndrome that they know in their community. Here's what we found. Over half of parents brought up what are called stereotypic behaviors. So this means repetitive behaviors. This can be hand flapping, twirling, head banging, rocking, spinning, or perseverative behavior, like doing the same thing over and over, like staring at ceiling fans, playing with the same toy in the same way over and over. This, I want to make a really important point here. Many kids with Down syndrome have some sort of repetitive self-stimulatory behavior. It's a relaxing thing that kids can do when they feel kind of stressed out, or it's a thing that they can do that can help them focus. You will see me, you probably have already noticed this, you will see me rock a little bit as I present. And that is because for me, a little bit of this repetitive stereotypic movement helps me focus, okay? I don't have autism. There was a study that looked at kids with Down syndrome only, without autism. So they took away the kids who also had autism and looked at the kids who had Down syndrome and did not have autism, and looked at how many of those children had some type of self-stimulatory behavior. They found that 60% of them have some form of self-stimulatory behavior. So this means that not every kid who stims also has autism. Now, what's different about kids with Down syndrome who also have autism when they stim? They do it more, and there's more types of it. And maybe it's more complex. Maybe it's not just a little rocking, but it's a rocking with some flapping, or it's a flapping with some specific way that I'm touching my mouth or that I'm touching my chin. And it's harder to redirect the kid, to make the kid do something else instead. So a kid might be so into the twirling of something that I might get to distract them for a second, but then they go right back at it. As opposed to a kid who's doing it because they're bored or they're tired for a second, but then you distract them and they're ready to move on to the next thing, as opposed to feeling like going back to that repetitive behavior. Not as many brought up abnormal play, but some self-stimulatory behavior can be interpreted as abnormal play. I have permission to play these videos from a parent. I'm gonna show you some spinning around a chair.
Go, Andrew, go, go. Andrew, let me see you dance. Let me see you dance.
And then mom
Go,
asks
Andrew,
him,
go,
show me how you
go,
dance.
go, Andrew,
And he's
go,
briefly
go,
distracted
go,
and
Andrew, go,
shows his
go, Andrew, go, 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 Andrew.
great dance moves.
Okay.
Then as soon as the engagement ends, right
Yes.
back to enjoy.
Spinning.
We're also on a playground with lots of fun activity and so much going on. And that's spending a heck of a lot of time just bouncing. So this could be interpreted as a stereotypic behavior. It could be interpreted as abnormal play. What other ways we might see a kid play a little differently, a little abnormally? A lot of kids with autism line up their toys instead of actually playing with them. They may sort them. They may. It's normal for younger kids to play by putting stuff in containers and taking them out. Okay, this is the way a younger kid plays, but over time that evolves into, and then I take the car and I make a drive and it goes broom broom, or I take the baby and I rock it and I feed the baby, or I put the baby to sleep, versus doing the still over time continuing to mainly engage in with toys by taking them out of a container or putting it back in. That idea of pretend play. So the toy is a symbol for something and I am pretending to do things with it is not as present. So if any of you have come to see me in clinic, you know that I ask you, how does your kid like to play? And then I inquire about how your kid plays with a stuffed animal or a doll or a dinosaur or a car, because what I'm wondering is the kid looking at the doll and maybe like just touching the nose or touching the eyes or shaking the doll, or are they also hugging the doll and maybe feeding the doll or putting the baby to sleep, or making the dinosaurs fight versus looking at the parts of the dinosaur, or making the cars drive as opposed to just looking at the wheels of the car. And then being able to be a little flexible with how we're playing with the toy as opposed to playing with it in the exact same way over and over and over. A lot of the dolls and the stuffed animals these days have some sort of cause and effect type component to it, where like the eyes light up or something lights up. So that's important for me to know too, because sometimes a kid's favorite toy is that teddy bear that lights up, but I still want to know, how is the kid engaging with it? It will be completely normal for the kid to be engaging with the toy by pushing the light up button some of the time, but I would still want to see the toy being used in some sort of symbolic way. Half of the families brought up some degree of impaired social skills, so preferring to play alone, less so interested in socializing with others, or being a little bit more withdrawn. What I can tell you, as someone who takes care of both children with Down syndrome and autism, as well as children with autism without Down syndrome, is that my kids with a dual diagnosis are still more social than kids with autism alone, which is what fools a lot of doctors that don't know a lot about the dual diagnosis, is that they see a kid who may give a big initial smile, who looks sort of social, and say, there's no way that this kid also has autism, and doesn't investigate further. It's just that it feels a little bit more difficult to keep that social interaction going. When I am working with kids with a dual diagnosis, I have to do a little bit more effort to keep them engaged, to keep them interested in what I'm doing. I have a harder time with them, with getting them to imitate what I am doing. We might do things like put a Lego block on our head and boop, make it fall down, and the kid might find it hysterical, but then are they staying interested, or are they going back to the other thing that they were doing, and will they imitate me in doing it? And also, one thing that I ask my patients is, how do they, does your kid try to get you to look at them when they're doing something, right? Or do they only point to things that they want, or are they also pointing to cool things? Like if they see a puppy, are they like calling attention to it? Are they pointing to the puppy or a plane in the sky or something else around them that's cool or novel? Is there some way of like calling attention to that thing? That's called shared attention, and that's something that's often seen a little bit less in kids who have autism. 40% of parents brought up language delays. And I don't have to tell a group of parents of people with Down syndrome that language delays are really common in people with Down syndrome. Of course, it's so difficult to talk when there's low muscle tone, a bigger tongue, maybe some hearing loss. There's just so much going on. That is why all my heroes are people with Down syndrome, because of the persistence in spite of how difficult some things can be. And yet people with a dual diagnosis seem to have greater difficulties with not just language, but also communication. So language begins to be acquired a little later. The pace of acquiring language seems to be a little slower. What I see in a lot of my patients with Down syndrome who don't have autism is they understand a whole bunch. They just can't say it back quite as well. Versus kids with a dual diagnosis seem to struggle a lot more with understanding some simple directions as well. I might see some more inappropriate speech where some of the words that are heard are repeating and only repeating, as opposed to some spontaneous speech or speech that's done for the purpose of communicating. Mom, dad, more. These are often important first words because they mean a lot, right? We want to call attention to people in our social world. And so if the first words we are hearing are consistently things that don't have something to do with our world and communication, but rather words that are coming up in a YouTube video, then there's something about the quality of that language that might clue us into something else going on. Some kids insist on calling themselves by their own name as opposed to saying me or I, or referring to themselves in the third person as opposed to referring to themselves as me or I. And that is also something that we can see in people with Down syndrome. I have a video I want to share next, and this is going to be the video of someone who has Down syndrome, has a significant language difficulty, but does not have autism. And what I want to point out in this video is, again, not everybody who struggles to speak has autism. What I'm going to point out in this video is all of the other communication that is happening with signing, with eye contact, with gestures. I hope the audio works.
How do you say happy?
Of course, the audio isn't working, and I don't know why. So, but I've watched this video often enough that I can tell you what is happening. So dad is asking the kid, how do you say this? How do you say that? And the kid is signing it. So.
Happy, good job.
How do you say happy? How do you say mad?
How do you say tired?
How do you say cry baby?
Cry baby.
And he's doing cry. And
so how do you say cry baby?
And he's looking at dad.
Cry baby. ¿Cómo se cry baby?
No, cry baby. And then he's saying, how do you say chillón? Which is cry baby. Cry baby. And then he wants the juice and he says, ooh, sister? Juice. And then he says, how do you say brother? Ice cream? How do you say sister?
How do you say ice cream?
How do you say ice cream? And he goes, yes. And then he says, how do you say ice cream?
How do you say
ice cream? How do you say cracker? How do you say cracker?
How do you say chip?
How do you say chip? You're signing it in the wrong place. How do you say bread? And he's slicing it.
Good job.
And then he goes back to looking at the juice. But you see that there's all of this checking back with different people in the room, checking back with dad, checking back for understanding, persisting in the social interaction. This is why if you come to see me, I start talking to you about signing early on, because again, there is so much to overcome with the mouth in terms of speaking, but having another form of communication beyond signing that bypasses some of those oral motor difficulties can help me a lot later on when I'm trying to figure out if there's an additional diagnosis at play. About 30% of parents who answered our survey brought up sensory issues, sensory sensitivity and defensiveness. Some of their answers included prefer to be isolated in low sensory environments, refuse to touch many touch type things like creams, lotions, haircuts, difficulties with loud noises, darkness, crowds, didn't like being touched by others. I see the main sensory thing that doesn't often get thought of as a sensory thing is feeding and being, and again, this is another thing where feeding difficulties are so common in people with Down syndrome. And so not everybody who has a feeding issue will also have autism, but when there's some pretty extreme narrowing of the foods accepted and a lot of gagging with different textures, it's just little things that I'm registering in the back of my head as I'm trying to figure out if there's another diagnosis at play. Crowds, but also whenever we laugh too loud or whenever there's too many people talking can be really overwhelming. And this can look like a tantrum that's not easily explained and is difficult to soothe. Another 27% brought up poor eye contact, including avoiding eye contact, not having eye contact at all. Most of my patients look at me in the eyes for a little bit, and the eye contact doesn't feel sustained. It doesn't feel like there's a communication purpose to it. Like if I do this, you know that I'm trying to tell you, hey, there's something over there that I want you to look at. And did you see that? But I don't see as much of that like eye contact for the purpose of communication. It feels more like oh, you're still here, okay, and then looking away. I see a lot of kids look briefly at my eyes, but then focus instead on my mouth or a different part of my body instead. Or they may look at me, but with a little side gaze. So just some differences in the eye contact. 27% of parents brought up that one of the things that made their kids seem different from other kids with Down syndrome was that they were taking longer to meet milestones. What I see in my clinic is that communication seems to be the area most affected, as we just talked about, but also some self-help skills like wanting to feed themselves or toilet training are particular sticking points where it just takes a lot longer. And of course, these are things that take time. You know, I know, you know, we all know that these are all things that take time. It just seems to take longer when there's a dual diagnosis. A lot of parents brought up mood behavior difficulties, including more hyperactivity, more anxiety, more self-injury, more difficulty with being soothed. This has shown up in the literature as well. And then 18% brought up a developmental regression as the way that their child presented. And about a third of children with a dual diagnosis have a history of regression, which is a rate comparable to children with autism without Down syndrome. It just seems that this regression occurs a little later. In people with autism alone without Down syndrome, it tends to happen around 2 years of age, versus in our kids, according to this one study, it was closer to 4 to 5 years of age. My take on regression, you've got to make sure you're ruling out medical things. Are we having seizures? Are we having low thyroid? Are we having a systemic disease that is impacting development? Have we had some hearing loss? Have we had some vision loss? And that should be par for the course in terms of evaluating regression. So some take-home points, the concern is not always that the kid has autism. It's rather that the kid seems a little different from other kids with Down syndrome, that that these differences tend to be noticed between 3 and 5 years of age, although some parents, of course, notice them earlier. That a lot of parents bring up their concerns to their pediatrician, who's not often good at acknowledging or recognizing or knowing much about the dual diagnosis. And that really the things that people are noticing are symptoms of autism, including stimming that's more complex and harder to redirect, a kid who may look social but act less social, significant language delays that are not just in terms of speech with our mouth, but also receptive understanding, as well as gestures and other forms of communication, and may have some more hyperactivity, anxiety, and mood and behavior difficulties. The next part of my talk is around assessment and interventions, but I want to pause and see if there are questions until now that we should answer.
Thanks, Noemi. We do have a few questions. The first one a couple of folks have asked is this presentation going to be available like in a PDF form as a reference for participants afterwards?
Sure.
So we can email, or is that I'm not quite sure if that's what
I mean, the presentation is being recorded and will be available.
Do you know, are we putting this up on our website? I know that with some presentations, we have them available on the website or a link to like a YouTube, where we could download it, or
I can put this on my website, and then there can be a link, and then I can give it to Nancy to put it on your website too. Yeah.
That's perfect. All right. Thank you so much. So the second question we have is, why is a girl harder to diagnose?
Yeah. Girls, I think I'm hearing feedback of what I say from your computer, Elizabeth. So girls in general have a little bit more of that pretend play, language, and kind of more social behavior. And part of it might be how girls are socialized. We're much more likely to give a doll to a girl than to a boy. And we're much more likely to sit down with the girl and play with a doll with a girl, so that the girl can learn how to look like she's playing with a doll, whether or not she's doing it spontaneously in a kind of pretend play kind of way, as opposed to a stereotyped way. And then again, just if we think about gender stereotypes of men versus women, women tend to be the ones who are bigger talkers to other friend groups. And there's just some things that come with the female gender that can be seen even in someone who has autism, just in less a way, right? And so if you see a little bit more of that pretend play, a little bit more of that communication, a little bit more of this or that, then you might not recognize that there's autism still there. I can't come up with a much better explanation than that, because I don't think we fully understand all the pieces that go into it at this point.
Thank you. And the last question I have here is, are you aware of the display of autism-like behaviors in response to health concerns? So for instance, stimming in kids with Down syndrome who are behaving in that way because of pain or discomfort from a persistent health condition?
Absolutely. So whenever there's any form of self-injurious behavior or repetitive behavior, one of the things that as doctors we're supposed to think about is something hurting, is something uncomfortable, is something going on that's making the kid kind of try to communicate that discomfort with the specific behavior. None of these signs or symptoms by themselves diagnose autism. It's more like a constellation of things. So if a kid is engaging in some repetitive behavior, maybe it's a self-injurious behavior because they are in pain, then part of the evaluation is supposed to be, hey, could something be hurting? Are there cavities? Are there dental abscesses? How are the ears doing? Is there fluid in the ear? Are we constipated? How are our joints doing? And so on and so forth. So absolutely, I think that autism-like behavior can be a manifestation of discomfort. But then I'm also gonna wonder, okay, what else is the kid doing? When else is the kid engaging in autism-like behavior? And is this the only context when we are seeing this type of behavior? And is the kid trying to communicate that discomfort in any other way, or are they just taking it out on themselves? Because while repetitive behavior, including self-injurious behavior, can be a way of communicating discomfort, it might still be a way that someone with a dual diagnosis expresses that discomfort. And so the two are not mutually exclusive, if that makes sense.
Noemi, if you don't mind, I have a couple more questions that came in.
Mm-hmm.
The first one is, my baby boy loves to stare at lights, but when calling his name, he immediately looks at me and focuses on me. Would this be a sign of autism? I did ask what his age was too.
Yeah, so there you go. I think that part of it depends on the age. A lot of babies like to look at things that have high contrast, like fans or lights. And then it's really good that the kid is turning when their name is being called. I think that these are things where we just continue to watch and pay attention and look at other things that the kid is doing. If this is a young kid and we are noticing this about the child, then we can also make sure that we start offering, again, those types of toys that can promote pretend play. So even if it's a baby boy, let's make sure that this baby boy has a doll at some point, and let's make sure that we are signing to this baby boy, and let's make sure that we are putting a lot of things in place so that as we continue to watch the child together and monitor the child's development, we can see if the looking at lights was like the one thing that they like to do that was sort of repetitive, or if there were other, or if there are other signs and flags that there might be another diagnosis at play. Even in children without Down syndrome who may have autism, the earliest that I feel comfortable really starting to evaluate someone is between 12 to 15 months and 18 months, just because there's so much growth and development that is happening. And so I would want to wait for some sort of developmental equivalent of that 12 to 15 to 18 months before starting to make recommendations for further evaluation in a child with Down syndrome. So if a baby is a baby, then at this point we watch and we continue to support the child in every other way, and we just kind of take it in the back of our head as one of the things that we can share about our child.
Okay, and then this question, my 19-year-old daughter was diagnosed with leukemia at 3.5. After chemotherapy, she had autism markers. It took us until she was 12 to get diagnosed with autism. Did the traumatic experience of leukemia chemotherapy bring out the autism?
So I want to start by saying that we don't know enough about autism in Down syndrome. We do know a lot more about autism in people without Down syndrome. And what we know is that there are signs of that are differences even in eye gaze pattern in newborn babies who will end up developing autism. So I do believe that there are differences in brain wiring and brain structuring that we're still very much understanding that tease apart people with autism and people who don't have autism. So if that's the case, then it's less likely that it was that was something traumatizing like chemotherapy that would have brought on the autism. However, I do think that going through chemo and going through cancer treatment is a really tough experience. And kids who go through this treatment go through a lot, and it's a pretty traumatizing experience. I think the word traumatizing or traumatic is the perfect word for it. And so someone who has autism or will end up developing autism might cope differently with it because of their differences in social-emotional characteristics. So I think that the experience of chemo can kind of bring to the forefront some of those symptoms of autism, and kind of make those symptoms look more obvious. Does the trauma of chemo itself cause the autism? I don't think so. Does the trauma of chemo itself or chemo change how significant or severe autism is? I don't think so, but these are off the cuff things that I'm saying because I don't have science behind it to kind of justify my answer, if that makes sense.
Thank you. And I have another question. I am a mother of a 10-year-old with a dual diagnosis. Do kids with a dual diagnosis have more sleeping problems?
Yes. Yes. So a lot of people with Down syndrome have sleeping issues, including really high rates of sleep apnea, much of which is underdiagnosed or undiagnosed. But kids with autism also often have difficulty settling for sleep, waking up really early in the morning. This is also true of people with autism who don't have Down syndrome. And melatonin tends to really work in terms of helping regularize some of the sleep cycle, but many of my patients are really early risers and do have quite a bit of difficulties with sleep. Yes, absolutely, 100%.
Since symptoms don't present until 3 to 5, is it common to have a younger child not showing any of these signs and all of a sudden start to show signs as they age?
No, I think that the thing is that it's around 3 to 5 that because the developmental range is so broad in people with Down syndrome, it isn't around age 3 to 5 that someone might say, I'm starting to really notice some differences. In Down syndrome clinic, we have the luck of meeting kids often at a young age and following them over time. And as a team, Mary Beth and I are constantly screening for signs of autism. And I usually have little notes to myself from much earlier visits of, I'm noticing this, I'm noticing that. Personally, I refer at younger ages than 3 to 5. So I usually see the signs of autism earlier than 3 to 5. The question here was, when did the parents of individuals with a dual diagnosis start really developing concern and noticing differences? And so I expect that a physician who is trained in development and has a lot of experience in Down syndrome as well as an educator, as well as a therapist, should be noticing some of these signs earlier. It is not, you know, all is well, and then all of a sudden, like, there's a complete change. It's more, there were subtle signs all along, and then by 3 to 5, they're obvious enough because there's an obvious enough difference from other kids with Down syndrome.
What do you know about the connection between gut and brain as far as diet is concerned?
This is a very hot topic in the autism world, in two ways. One is, there are theories around the microbiome, so the bacteria that live in our gut, impacting our immune system and our brain development and our neurotransmitters, and differences in that microbiome between people with autism and people without autism. And this has not been studied in people with Down syndrome. Okay, so I can't give you a good science answer, a clear yes or no. I do often recommend probiotics, but not just for people with Down syndrome or a dual diagnosis, but for everybody, because there is enough good evidence out there that a healthy microbiome can help with a lot of things. I always recommend cautious use of antibiotics, because antibiotics are going to impact the gut microbiome. And then anybody who's ever talked to me knows that I'm going to talk to you about healthy diet with trying to maximize fruits and vegetables and fiber, and trying to avoid processed foods, and avoiding rewarding with junk, and not just because of concerns around excessive weight gain, but also because of the nutritional content of those things. The other piece around the gut and the brain is a different spin on it, and that is that the sensory way that we interpret the world that I brought up, like those sensory concerns, loud is too loud, bright is too bright. The tag on a piece of clothing is like the worst thing ever. The crunch is too much. All of these different sensations can also be interpreted differently when there are sensations inside our body. So a fart or gassiness can feel so incredibly upsetting and can feel really dysregulating to a kid, and can worsen the behavioral signs and symptoms of autism, because I'm just not comfortable. And that is something that we see often in kids with autism, and we should think about in terms of kids with a dual diagnosis as well. So those are two different spins on the question of gut and brain. And because I see a question around daily vitamins and supplements, since it's on the same topic, I maximize vitamin D. There's some small evidence that good vitamin D levels improve cognitive and speech outcomes. This is from the autism only research, not the Down syndrome research. But when you get blood work ordered by me, you get a vitamin D level, and then usually get a call saying the vitamin D is low, supplement with some vitamin D. Most of us are deficient, and there's a lot of interesting research around vitamin D, including that good vitamin D levels improve outcomes from COVID. So I usually recommend a vitamin D supplement. I like probiotics because they can help with gut, and issues like constipation are just so common in our patients. And then a lot of the rest can really be ensured by a healthy diet. If someone has a really restrictive diet, I usually recommend a multivitamin, which can supplement what might be missing from a diet that's poor in fruits or vegetables because of picky eating. There's no evidence that other supplements, including things like Nutri-Vene or other supplements, there's no evidence that they work. They are quick to claim that they work on everything without any evidence behind it. My take on that is that you will not be told by me to go spend money on these supplements because I don't have evidence behind it. If this is something you choose to do, just talk to me about it to make sure that we're not overdosing on any one vitamin. I have had patients who were taking too many types of these supplements that were promising that it was going to improve cognitive outcomes, and then we were getting toxic levels of vitamin A and vitamin E, which can be harmful to the liver. So I want to hear about it. I want to do my reading and research to support your reading and research, and I just want to make sure that we're doing it in a way that's safe. I'm not going to try to talk you out of something. I'm just going to be straight with you about the evidence behind it.
Are children with Down syndrome more susceptible to having infantile spasms?
Yes. But they also do better. So people with Down syndrome are more likely to develop infantile spasms. They're more responsive to treatment. They're less likely to develop some of the more severe epilepsy syndromes that kids without Down syndrome who have infantile spasms get. Again, I find that the issue is that these things get delayed in diagnosis and recognition, because so often the answer is, it's just Down syndrome. I brag so hard about how a lot of my patients that I diagnosed with infantile spasms have done so well, because patients send me the videos right away, and I'm like, yep, we got to evaluate. And, sometimes we send them for an EEG and it's normal and I'm wrong and whatever. And sometimes I send them for an EEG and it's positive and it's only been a week of symptoms, and then the kids are doing really well. So I think that this is where I say what I always tell every parent, which is, you're the expert on your kid. Feel free to be pushy, and feel free to say, you know what, respectfully, I want to see the neurologist. You know what, respectfully, I want this EEG to make sure it's not infantile spasms. It's totally okay to be a little pushier.
Okay. I have a question here from Aaron. Ramare, who is 6, was diagnosed with ASD at 3. He was actually seen by 2 different evaluating psychologists over a period of 2 months, and one said he did not have ASD, and the other said he did. In my research and observation, including some of these things you've talked about today, there are ASD patterns that my son definitely does not have. For example, he plays with his toys. He does not fixate on the parts. He has no problem with crowds or loud noises. However, he has significant language delays, does have uneven social behaviors, and does have a hard time stopping his vocal stimming. Given that even the diagnosis is not super clear, I've always struggled with how to think about it. Do I claim the ASD as another diagnosis for him? Do I not mention it? Do you have any advice or insight on a situation like this where the diagnosis isn't totally clear?
So how about I use this question to dive into the next part of the presentation, because I gotta let Teresa talk too, because I'm gonna talk about the evaluation, and I think it's gonna answer quite a bit of this question, and then we can take the rest of the questions at the end, if that's okay.
Okay, I think that makes sense. And
Okay.
we'll make sure we address your all's questions, folks. And thank you so much, Noemi. That was a lot.
For sure. I want to be able to answer everybody's questions. I just also want to make sure that Teresa gets to tell you about her piece, because it's really important. So how do we evaluate? Because this is kind of exactly what this question is about. We have, not only do we have little evidence around autism, we have little evidence around how to best evaluate people with a suspected dual diagnosis. I always start with the basics. Know how someone hears, know how someone sees, check how their thyroid is doing, do all of your screening labs. I should have a bullet point here around sleep. Make sure you have your medical basis covered, of course. There are several assessment tools that have been looked at in the literature. This is a jargon list. One thing that every pediatrician office has is something called the MCHAT, the Modified Checklist for Autism in Toddlers, revised with follow-up. This is supposed to be given to all children between the ages of 16 months and 30 months. This is developmental age. It often corresponds to chronological age, although of course in children with Down syndrome, it might not correspond. It's a 20-item yes or no screener. What I have seen is that a lot of patients that come to me have not had the MCHAT done. When you're my primary care patient, you best believe that you get this at the 24-month visit like everybody else. The MCHAT is not a diagnostic tool, it's a screener. So it's supposed to flag kids for whom we might have a greater concern, okay? So we want from a screener a tool that is pretty sensitive, so it's gonna catch as many of the kids who actually have autism as possible, but it doesn't have to be very precise. It doesn't have to be very specific. Some of these may be false positive. It might lead to more evaluation than necessary, and that is okay because the idea is wanting to catch as many of those who need to be caught as possible. One study suggests that in kids with Down syndrome under 60 months or under 72 months, if they're nonverbal, the MCHAT can be up to 80% sensitive. Usually when I get an MCHAT, there's a couple of responses that flag even in kids where I do not have a concern about autism, because some of the questions ask if the kid talks or how well the kid talks. And so, of course, if we have Down syndrome, it's very likely that language will be impacted in some way. So I expect that it's just how many of those other ones are positive and are flagging where we might have a higher level of concern. There's a couple of other tools that I want to mention. One is the social communication questionnaire. One is the aberrant behavior checklist. Both of these have been studied a bit more in the Down syndrome autism literature, and you are unlikely to get them at a pediatrician's office, but you may be offered these screeners from a psychologist, for these tools from a psychologist or even a school psychologist. What you will likely see if your child is being evaluated for autism is something called the ADOS, the Autism Diagnostic Observation Schedule. It's a very structured way of playing basically together with the kid. It starts with a period of free play, and then there are specific things that the examiner is supposed to do. They're called social presses. The examiner is asking the kid to do things, or they're themselves doing things, and then watching for specific ways that the kid will respond. And then they're taking notes, and then there's a whole piece of it that's an algorithm that's supposed to score different things, include that then correspond to things like complex mannerisms, so that's the stimming, repetitive interest, stereotype behaviors, tantrums, signs of anxiety, self-injurious behavior, the way someone is playing with objects, unusual sensory interests, shared enjoyment, shared attention, response to joint attention, and the quality of different social overtures, as well as the amount, eye contact, things like pointing and gestures, including communicative gestures, facial directions, showing something, how we're using our eyes and our gestures or behaviors together, how often we're vocalizing and talking, and whether the talking is just repeating versus back and forth talking, social smile. All of these are things that are graded on the ADOS. And what you see in the green boxes are things that correspond to some of the things that I showed you in the previous slides. And the ones in bold are things that actually get points when we score the ADOS. So this is where I think I can answer the question that was asked right before I went back to presenting. To receive a diagnosis of autism, you don't have to have every little thing. You just have to have enough things to meet a score for autism, because autism is a broad spectrum and people with autism are very different and present very differently. So I think that it's expected that different kids will have different presentations and signs of autism. Some kids are better at engaging with toys. Some kids are better at the social piece. Some kids have less sensory stuff and some kids have more. Some kids have a lot more language than others. So there isn't one. When I was presenting the different ways in which kids present, this is not a gotta catch them all kind of thing where you have to have all of them. It's you have to have enough of these things to kind of meet a certain score on something like an ADOS. And that is the imperfection of psychology and psychiatry, is because it's not a blood test, because it's not a picture, but rather a combination of things on a spectrum. It's kind of like you can have a couple of things, but then if you have enough of them to get to that like magical threshold, then we call it. So what we in DSMIG and the Down Syndrome Medical Interest Group have recommended for assessment is a parent interview, talking to teachers and therapists, doing some structured things like the social communication questionnaire and the aberrant behavior checklist, the Vineland, which looks at cognitive functioning, and then doing the ADOS as ways of as a battery of tests to diagnose autism in a child. And then I want to get to the other piece of the question by talking about how do we support people with autism? And I'm going to be briefer on this because I know Teresa is going to talk about this. So again, there's not a lot of evidence around how to support people with a dual diagnosis. I think it's important to, first of all, set goals, keeping a long-term perspective, but then breaking that down into goals, like achievable goals that can be met short-term to support that long-term outcome. So my long-term goal might be, I want my kid to have a really high quality of life. I want them to be independent. I want them to be safe. And then that might translate into, I want their communication maximized. I want to support their social functioning. I want to help different aspects of self-care. I want to get them to attend to something a little bit longer, or be more willing to comply with an instructor, or learn how to wait a little bit. When we asked parents what were some things that you thought were relative weaknesses in your kid compared to other kids with Down syndrome, communication deficits were brought up the most. Being a little rigid, like not being super flexible about how things are changed. The social skills and the mood and behavior issues, as well as the dependence on caregivers for activities of daily living, were brought up most often. So these can be good targets for treatment. We asked parents, what were things that were helpful? Main answer, ABA. Second best answer, PT, OT, and speech therapy. Then school, parental support, other behavioral interventions, Down syndrome clinics. So this is where I want to also answer that other question of if I'm not quite sure about this diagnosis, do I claim it? Well, I think that diagnoses are, your kid doesn't magically transform. It's not like those old Pepsi commercials where like the zipper comes down and Britney Spears comes out, right? It's the same kid before and after the diagnosis is received. The diagnosis is describing some of the things that we are seeing with a unifying word that can be the key to open the door to a number of services. And I know that Teresa is going to talk about this, so I don't want to delve into this further other than to say, sometimes ABA can only be accessed if you're claiming the diagnosis. Sometimes certain waivers and other supports can only be claimed if you're claiming that diagnosis. So I think that part of whether to claim it depends on whether it's impacting your access to services. I don't think we have time to watch this video because I need to let Teresa talk, but this is a video that's available on YouTube that shows an example of ABA in someone with autism and Down syndrome. And I know that there will be more parts to this webinar, so I'm not worried, the webinar series on the dual diagnosis. So I'm not worried because I know that this will be addressed. I just want to point out that parent training can be helpful if ABA is not available. We are in the middle of a pandemic. While some ABA is being done in person, other families are preferring to do video consultation with ABA providers. And this, to me, I kept this slide in as a reassurance that if you cannot have the ABA happen in person for whatever reason, you being trained as a parent on the specific skills for ABA can be really helpful too. Supporting communication is important. This is an example of a PEX board, and this kid is trying to ask for applesauce, and so he is pointing to the PEX for he needs to be prompted, but I want, and then he looking for applesauce, and then he ultimately just points to the applesauce right there because he can't find it on the PEX. And then this is a higher tech device. And again, what you cannot hear in this video is that he is pushing the buttons to say, I want applesauce. And then he gets the applesauce. And then this way he doesn't have to throw whatever is in front of him or hit himself or feel really, really frustrated because he wants applesauce without having a way of communicating that. I just want to say this because I think it's important and I think it reflects a lot of experiences. We asked parents in our survey, was school helpful? Like, just like that. And 36% said, nope. And I think that this just highlights how for school to be helpful, it needs to really meet the needs of the child. And that might be another reason to actually claim that diagnosis, because if we are not recognizing that there's something else at play and we are insisting on the same old pattern of education, the same old model, the same old thing, without the necessary accommodations, modifications, and programmatic support and services, then school might feel a lot like torture and we might see a lot of behavioral difficulties. And so that might be another place where claiming that diagnosis is important. And there are structured teaching curriculums such as Teach that I know the Down Syndrome Connection has a lot of webinars about that highlight the importance of physical structure, scheduling, having a work system and a routine with a strong visual structure that can really help individuals with autism thrive. Any intervention, the outcomes are related to how much of it we're doing, how consistently we're doing it, what else is going on in someone's life, as well as some characteristics of the kid, including someone's cognitive abilities and language abilities, and any other comorbidity that might take precedence over the treatment of autism. I'm going to be giving a webinar on medication on March 13th, along with a psychiatrist from the University of Colorado. So I'm not going to dwell on this other than to say that there are different medications that can address different symptoms that can be seen with autism, but also with Down syndrome without autism. Each of them has some good benefits as well as some potential side effects. And that really the goal always, the way we should approach medication always is to set clear goals. So this medication is not going to undo the autism. So what is it going to help with? Is it going to help with self-injurious behavior? Is it going to help with hyperactivity? Is it going to help with attention? Is it going to help with anxiety? Know what you're treating so you can monitor whether it's working or not. Always start low, always start lower than low, and then go slow, because we don't want side effects to go unnoticed. There may be side effects and we need to know what to look out for. But again, starting low will make it so that if we get a side effect, we're not going to get a big dose side effect, but rather a little dose side effect. We should be seeing the doctor often, and when possible, involving a psychiatrist or behavior and development doctor, although I'm fully aware that those are rare unicorns in our area, which is why I've taken this on as one of the things that I do. So as take homes, ABA can be helpful, parent training can be helpful, a school needs to be structured, communication support is key, Down syndrome clinics can be helpful, and considering medication as important. For some families, receiving the dual diagnosis can be liberating. It wasn't something I was doing wrong or not enough of. There was just something else at play. The diagnosis can explain differences in a way that was beyond anybody's control, right? And then can give us a path towards, instead of trying harder, trying different, something that might work more effectively than what we have been trying so hard so far. But also recognizing that receiving the diagnosis can be heavy for some families, and the need for all of us as providers, but also as a community to support. The Down Syndrome Medical Interest Group put together some recommendations for caregivers that include, if you are concerned about autism, make a list of what you're concerned about and share these observations. And if there's a lack of concern, ask for a second opinion. If you're concerned, seek a formal evaluation. Seek two if you have to, like the person who asked the question earlier. And understand that an additional diagnosis can lead to more support. Be aware that there are a number of things that can be used to screen and diagnose, and then learn more about autism. Of course, I don't have to toot the horn of the Down Syndrome Connection when I'm presenting for the Down Syndrome Connection, but y'all are amazing. The Down Syndrome Autism Connection is a support organization that's web-based and specifically geared towards supporting people with a dual diagnosis. There's a couple of books out there. Teresa is the author of one of them. An older one called When Down Syndrome and Autism Intersect is also a good book. And then there's some handouts on NDSS. We at Down Syndrome Clinic are here to help, and on our website, there's a lot of information that I have been gathering over the past year and a half that everybody's free to access. And I just want to acknowledge the Down Syndrome Medical Interest Group, because we are all working together to expand our existing knowledge so that the next time I present, I can have even more information for you. We're all working in a coordinated fashion to expand knowledge. I want to pass it on to Teresa before we take questions, if that's okay, because I know I went way beyond my time.
Thanks, Dr. Spinazzi. And also, before we pass things on to Teresa, I want to make sure that Teresa has an opportunity to present the material. We know it's important to you all to get all the information you can. And therefore, Teresa, if you end up going beyond the time needed, we do want to offer that extended time to participants who do have the time to stay with us to ask questions at the end of this. I just wanted to go ahead and offer that, extension so that Teresa, you do have an opportunity to get in everything you need to get in, since this is such a valuable information and we've got a lot of folks joining us today. So with that, Teresa, I'll go ahead and pass it over to you, and we'll go from there.
Thank you. Thank you, Dr. Spinazzi. Wonderful presentation as always. So I'm going to start again. My name is Teresa Unnerstall. I'm the Down Syndrome and Autism Dual Diagnosis Consultant for the Down Syndrome Connection of the Bay Area. I am also the author of a new course, A Mother's Journey, Navigating Down Syndrome and Autism, and that's my website where you can access everything about this and more. So this is my son, Nick. He is 26 years old. He does have a dual diagnosis of Down syndrome and autism. He currently is, normally is in an adult developmental day program, and it's a very fulfilling program that he hasn't been attending, but he usually does. So here's an overview. I'm just going to very briefly, I'm going to kind of blow through our experiences with the evaluations, and you're going to see some things echo from my experience, our experience that Dr. Spinazzi talked about. We actually had one at age 5, some red flags, and I'll kind of go through those in just a second here. And then I'm also going to talk about just working with the IEP team to address autism and the 4 main key areas that I see can really impact a difference for your child or the child that you're working with. And then just some supports. So you're going to see some overlap because we've actually done this presentation before, and oops, wrong way. So I guess what I'm saying, I'm probably going to blow through some of it because she's already covered. So here are some of the red flags we saw at age 5. He was definitely doing some stimming, tapping, rocking, seeking extra stimulation from the environment, a lot of vocal stimming. Engagement wise, he all of a sudden sort of just quit wanting to do itsy bitsy spider. I noticed that his speech wasn't developing, and the OT at the time noticed that he had sensory integration disorder. So some of those things kind of overlap. The final thing is the self-injurious behaviors, which are SIBs. We actually did live in the Bay Area, and that's in Livermore. It's a winery, so I think it was Concannon. And this is Nick at Half Moon Bay, and I point this out because if you see right here on his cheek, he's got a scratch. In retrospect, I can see that the sand was a trigger because it's very coarse, and imagine for someone like Nick or an individual that has autism, something like walking on sand might have felt to him maybe like walking on glass. So he was really aggravated that day. Oh, wait, okay. So we did an evaluation with a developmental pediatric psychiatrist. At that time, autism was ruled out. Basically, the test was very simple. It was a parent interview, questionnaire. She probably watched him play with some blocks, and I noted to her I did not see a flip of the switch or regression. So the report indicated that he had, good eye contact. He was very social, and most likely it was the result of the sensory integration disorder and verbal apraxia, which is kind of a mind. The connection from here to here wasn't coming out, so his speech was delayed. Fast forward to age 10, I'm located now in the Chicago area, so we started seeing some more red flags, increase a lot more stimming and a lot more of the self-injurious behaviors, more hitting himself, frustration, just, totally amping up at age 10. A lot of aggression and meltdowns at home and with the school staff. You've got to tie in puberty and hormonal changes. And I will say, of all the milestones that take a little longer for our kids who have Down syndrome, the puberty was the one that not only hit, but I think it was actually early. We also had some pretty significant delays in toileting and speech, and just the social interaction. We had the Gigi's Playhouse Down Syndrome Center here, and he was not doing parallel play. He was more off on his own. And we, as parents, started to feel really isolated from the Down syndrome group. And, just because we noted the differences. So like I mentioned, puberty, we were really in over our heads, and the plan we thought we had was not what the plan we were on. So I put this frustrated one because not only was Nick getting frustrated, but we were too. So what do? We asked the school about getting an evaluation. They said we don't need to have that evaluation because you already have a primary evaluation of Down syndrome. We can work off the IEP. We decided to take the bull by the horns and get our own independent evaluation done and pay for it ourselves. And that's when he got the secondary diagnosis of autism at age 11. So I called an IEP meeting. I brought the report, and it was an expensive evaluation, but worth every penny, because we were able to get to really address the complex needs that Nick was having, resulting in this secondary diagnosis. We brought in a BCBA board certified behavioral analyst to do some observations, and they made recommendations. They put together a FBA, which is a functional behavior plan, collected data, and then we basically from there were able to create a positive behavior support plan to support Nick. We got training in the PECS picture exchange. At the time, we were using the pictures, and I will back up to when we were in California. I had just photograph pictures that we used. And, you know, this highly preferred items like goldfish crackers and Capri Suns and Barney videos, Thomas the Train videos. So he was using that. And then we were integrating some PECS pictures at the time, but what I realized from the training is we weren't using the PECS properly. And so once we got trained, it really made such a difference. And when we do our webinar about speech and AAC and communication, I'll be sharing much more about that with you. We were able to get additional supports like using visuals, schedules, social stories, task strips, and that really, to me, visuals and individuals with a dual diagnosis can benefit so much. It's like a blueprint that they can follow. If Nick can see it, he can understand it, what's expected of him, and that's going to, whether it's a schedule or a task strip, that's going to help him understand, and his anxiety will lower and less chance of escalating into frustration, and ultimately what you don't want is a meltdown. So somebody asked the question about should I put this secondary evaluation in the IEP? My personal opinion, that's what was the key that unlocked the door for more services and support to maximize your child's potential. So here's the good stuff. 4 key areas that helped our family and our son. First was the speech and communication component, and looking at alternatives. Not only, we always did sign language, but using AAC, low tech. You've got low tech and high tech options, which I'll be showing you in a bit. ABA, game changer. Find the behaviors that you want to target and support your child. Collaborating with an occupational therapist, an OT, to get possibly a sensory diet that can help regulate the child. And then the final piece of the big 4, I like to call, is looking possibly into applying for a state waiver for funding. This can get you in-home family support, caregivers that can come in, give you a break. You can still have a life. I can still go teach my fitness classes. My husband can go golfing or playing tennis, and, you know, keep us sort of balanced as a whole. So I mentioned about visuals and how they can navigate the smoother seas, and I'm going to give you some examples here. So this first, this is low tech and high tech. We still use all of these because you never know when the iPad's going to get thrown or not be charged. So it's always good to have a total communication approach. And the one that Nick uses is, just so you know, is a GoTalk. There's a few others out there, but again, when we get to the webinar about AAC, we're going to have a boatload of information for you on this. I will also, I'm very proud to mention that the Down Center Connection of the Bay Area has a full low-tech communication board library, you name it, hygiene, I am feeling, going to the dentist, going to the doctor. And when you go into that, you can, it's a Padlet, I believe. We can probably get that I think you can just go to the Down Syndrome Connection website to access that, but we'll make sure you guys get that link for the communication board library. And these are nice because they're portable. You can print them up, you can carry them with. They can also customize these for our members of the Down Syndrome Connection of the Bay Area. And again, back to visuals, because if you can see it, you can understand it. There, you can go more high tech. This first one here is a First Then app, and there are so many different boards available for that. A lower tech version here is, this one's actually I use when we go to the dentist, and I will literally point out, okay, we're gonna check in, we're gonna wait, and I'll go wait, and then say hi, and then I'll literally, as he's counting teeth, I'll point this, and you can see that Nick is a lot calmer because he sees, okay, now we're doing this, now we're doing this. Then on the treat, I usually put Taco Bell in there because he loves Taco Bell. Oh. Here's another example of a task strip, social story for toileting, and this one actually is in the library, the low-tech library we have it with the Down Syndrome Connection. Other strategies, using a schedule. This is a very simple one. First, then, okay, first we're gonna do our work, then, you know, you get your reward, and maybe this could be anything. It could be computer time, it could be music, headphones, iPad, and from here you can make these a lot more sophisticated as your child, you know, depending on the developmental level of your child. So here's Nick using a visual schedule. This was in high school. What I found with Nick is that the more that we can give him control, his anxiety level's a lot lower. I think that's kind of true for all of us, actually, when you think about it. So he's able to open the schedule, put that on the schedule. He's going to swimming there, and you can tell he loves that. He loves swimming. So, oops. All right, so I mentioned a lot about visuals, but another piece is the ABA, the behavior. So this is an example of data collection card that can be used. You define what behavior that you want to work on and make some data collection. So for instance, let me just do one off the top of my head. Let's say Nick's or your child's in school and the work is set in front of him or her. They start pushing the desk, okay? So let's say that's age 10 when Nick was hitting pre-puberty. I'm gonna go ahead and use him as an example. Pushes the work away. Well, why is he pushing the work away? What happened before that was, and you could put this on the ABC, the antecedent, was the work too hard? Was the room too loud? It could be a multitude of things. And then you write the behavior. Well, he took the work and threw it and pushed his desk, and then the consequence to follow. You'll note down here are some possibilities. Maybe, again, if it was the work's too hard or it's too loud, the escape might be wide. Sometimes it can be sensory, sometimes it can be attention seeking. So whenever you think of behavior, think of the these components, EATS, so escape. A is attention seeking, T is tangible, maybe they want something or they need something, and then S is sensory. That's kind of an easy acronym. Just and again, we have that behavior work webinar, and that will be in May, and we will be giving you guys some great information about that. That is specific to a dual diagnosis. So OT and sensory diets, certainly, make sure I didn't skip anything here. Okay, here we go. As Dr. Spinazzi mentioned earlier, we all have a need. She said she's she, you know, to alerting activity for her to keep focused. She's rocking. We're probably all doing something like that as we get into almost the second hour here, at the end of the second hour. Maybe you're doing your leg or twirling your hair. Maybe you're thinking, I need a cup of coffee right now. Neurotypical individuals, we can regulate ourselves. Someone who has autism or a dual diagnosis may need some support to do that. And so what a sensory diet can do is you kind of implement activities through the day to support them. It could be anything from heavy work, which can be organizing. It could be something like a fidget, which would maybe take the place of hair twirling. There's so many. And again, we are so excited to bring that piece to you in one of the upcoming webinars as well. We'll be covering a lot of that. All right, so I just want to talk a little bit about advocating, whether you're a parent. I noticed, thank you all for putting in the comments the ages of your children that you're working with or a parent of. And I see a lot of you already have a lot of teenagers, which is really cool, that have that dual diagnosis. So these are just some things to help support you guys, or if you're a teacher, physician, clinician, kind of keep these in mind. So first of all, seek support. You can't do it alone. And it's not necessarily going to be with a group that is, you know, a Down syndrome support group. Not all these groups have extra support for, additional support for dual diagnosis. We're fortunate enough with the Down syndrome connection to have that piece in place. So. And then collaborate as a team at the IEP meetings, you know, really looking outside the box for solutions. Quick example, when Nick was fifth grade, he was not having the handwriting goal. A pencil to him was better to throw or just scribble on his, you know, clothes. It was not meaningful. So we got together, the whole team, and said, what can we do? You know, is this goal, if this goal isn't meaningful, is it going to be relatable for him down the road? So you kind of have to look at that as well. So we changed that goal to typing because most of us, you know, are on computers. So we adjusted that goal. We kind of thought outside the box and came up with that solution. And then really look at what supports and accommodations are needed to make that learning the most effective. So these can be what I've already discussed. It can be visual schedules. It could be task strips where you're breaking down something that's a little more complicated. For instance, a handwriting goal was not happening for Nick. It did work a little bit. We used to have it match N-I-C-K, and he'd draw the line to the other side just so he could recognize his name. So that's one way. And then when we revisited the goal at age, or fifth grade rather, we made put a piece of cardboard with the cutouts of N-I-C-K on the keyboard so he could go and type and only not see the whole keyboard. So that was just an example of a modification you could do. And then you may also want to find some additional training for your staff. Because I mentioned earlier, meltdowns, that's the ultimate thing that you don't want to happen. So if you have that behavior plan in place, you can look around your environment and go, what is it that escalates my son's behavior? Well, in Nick's plan, you would read that if he starts biting his bracelet, he's got a medical ID bracelet, he's getting a little stressed out. If he starts throwing things or hitting himself or pinching his own cheek, you've got to shut that down. You've got to get it leveled off and try to cut that off at the pass. Unfortunately, meltdowns do or can occur. And so it may be necessary to ask for a CPI training, which is crisis prevention intervention training, where you learn how to safely get the person who is in a meltdown mode state and get them safe and calm down, and also protect the staff that's working with them. And then I also, in the past with Nick, they have used his behavioral support plan, kind of made like a smaller version of, let's call it a cheat sheet, okay, for the aides, so that they know, okay, if this room gets loud and Nick starts biting his bracelet, then we need to offer him a way where he can take a break. Maybe we give him his noise canceling headphones, or a break icon, or take a little walk in the hall, just to avoid letting that escalate further. And then safety concerns with the building. Elopement is something that should be carefully monitored, and then all these should be written in the IEP. Does the child need a one-on-one aid? If that aid is going on break, making sure that if you're out at the playground, someone else has their eyes on a child that's eloping. Or I should also add, fire alarm pulling, like my son. So he's got a little penchant for those. All 55 of them since 3rd grade, so. And then just giving your child a voice at the IEP. I mean, I also mentioned here, you see the break card right there. So those are, some examples. But when Nick got into high school, he was actually at the IEP meetings and did his own presentation. It was put together using a PowerPoint. So he got to show them his favorite music, his hobbies, and he advanced the button on those meetings, so he's a part. And he had his voice. That was really cool. Finally, I can't say enough about leading with the strengths and an IEP plan. Nick's strength is definitely knowing where things go, matching. And so you'll see in the next few slides that I'm going to show how that goes into play. So here Nick is in high school, and he is working at a Restore, which is kind of a resale of home goods. And basically, here's the example of a task strip where he puts these knobs on, and then he'll put those in a bag, and those will be sold at the store. Of course, in this picture, you can see he's getting a little sensory thing there. He's looking at his reflection in that knob. So, and you can also see he has a one-on-one para as well. Here he is later at, again, this is high school. He is working at a assisted living facility. He loves to vacuum. So it's like, well, let's get him a job vacuuming and doing some maintenance. So the way we taught him to move the vacuum, they would take hole punch holes, a whole bunch of them, the kind, and then just sprinkle them out all over the ground. And that way he wouldn't just stay in one place and just vacuum one area. So that was another job he had. And then I like to also add this picture because he loves swimming. He's highly, it's a highly preferred activity for him. In high school, his adaptive PE teacher said, why don't we try this program called Dive Hard? And I'm like, oh my gosh, Nick won't even wear hat and gloves when it's 20 degrees here in Chicago and it's snowing. He'll just fling them off, throw them. That's not gonna work. She's like, no, I got a good feeling. Let's try it, because this Dive Hard program is an adaptive scuba diving program. Well, sure enough, he not only put all the equipment on, he went underwater and he wouldn't come out of the water for probably 20 minutes. So never set limits on your kids. That's why I like to include this picture as well. So some additional supports. I mentioned already the state waiver for in-home family support caregivers. And it will also cover, depending on your state where you're at, but it can cover equipment, some ABA as well. I mean, it depends on your state. Respite, care support. I mean, this can be a burnout position as a parent with the additional and more complex needs of a dual diagnosis. So it's so critical to have that extra support to help you out. And I will just give you a little tip, because a lot of people say, well, I've got respite care, but I can't find any good workers. Well, the best workers that I have had over the years are the teacher's aides that are already been working with Nick. So that's my little tip to you. If you also college students who are studying in the field of special ed are great resource as well. Support for our families here, not here, in the Down syndrome connection of the Bay Area. I am the consultant, and we do offer consultations for our members. I as well offer them independently from the Down syndrome connection of the Bay Area. And then I highly recommend finding groups that are specific to co-occurring Down syndrome and autism. The gold standard is the Down syndrome connection, dash autism connection there. And I left you the website. And then also within the Down syndrome connection of the Bay Area, we have a dual diagnosis Facebook page. It's right there. And we'd love for you to join. And all these, let me also mention the Down syndrome autism connection has a private Facebook page for families that have a dual diagnosis as well. And then we have a great resource library and links on our website. When you go to dscba.org, you can click over to education and then drop down to dual diagnosis, and you'll see a whole bunch of our resources there. And then just want to re-mention that I have written a book. It came out in May. It's a hybrid of a memoir of my journey navigating this dual diagnosis, but with that also at the end of each chapter I have some takeaways. It's all like a 3-2-1 kind of a play on the 21st chromosome, 3 pair, or 3 in that 21. And you will get the lessons I had learned at the time and some of my takeaways. And then at the very end of the book, I have my version of an appendix, which covers every single topic you can imagine and then some. So whether you want to, it's a good reference where you can, okay, what does she have to say about IEPs or traveling or going to the dentist or family dynamics? That is a gold mine of help that I wanted to offer you all. And then also my blog at nickspecialneeds.com. That's a blog I've been writing since 2012 that you can type in the search engine, whatever, toileting or AAC, and all the blogs will pop up about what I've written about that as well. So I believe that is what I have for you all. So we're going to open it up for questions. And again, thank you all for coming. And I just want to mention the next webinar. All these webinars for our that focus on those needs for a dual diagnosis are the 4th Saturday of the month, same time, 10 a.m. Pacific, and that'll be noon Central. And next month we'll be doing some structured teach activities with Elizabeth, and myself, and then from there we'll also address the occupational therapy and sensory. We will do the speech component and behavior. So we're super excited that you guys to be able to offer that to you all. All right, so I'm going to exit my slide and let you guys jump in on some questions here.
Thank you so much, Teresa. Both Teresa and Dr. Spinazzi, what a wealth of information. I know we have a lot to take in here. And I will go ahead and address some of these questions, ask these questions, and you guys can decide who's going to address what. Will an adult with Down syndrome have autism in his, sorry, dogs. Will an adult with Down syndrome have autism in his mid-20s or late 20s of age?
So I would say that a 20-year-old probably has had, if they have autism, they've had autism for a long time and they've gone undiagnosed. Autism is not something that goes away. It is something that changes over time, like we all change and evolve over time. So a little toddler with autism will be doing different things than an adult with autism. But yes, you can absolutely have in front of you someone with undiagnosed autism, and can they be diagnosed at a later age? Yes. To be diagnosed with autism, you just have to show that the signs of autism were present earlier on in life. I do want to call out, there is an entity called Down syndrome regression, also known as Down syndrome disintegrative disorder, that has been described in the literature as quote unquote adult onset autism. And this is where people who were not showing signs of autism at all undergo a significant regression, usually in their teenage years. Sometimes there's a clear and identifiable traumatic event that triggers this, and can begin to display pretty significant autistic behaviors. And this is not the same as having a dual diagnosis all along, though you might now meet criteria for autism. This is a whole other topic that I won't delve into more for the purpose of this presentation. It's a very active area of research and requires thorough evaluation by a team of specialists.
Thank you. Dr.
Yeah,
Spinazzi.
let me
Oh,
also
sorry, go
add
ahead,
that.
Teresa.
Let me also add, I'm kind of curious as to when this regression might have started happening, or was it there all along? Because in my experience personally with Nick and this lockdown, he hasn't been in his program since March. There's significant regression in behavior and a lot more SIBs and throwing and just frustration. You can sense it, even though, because he's not in that structured program. So, kind of factor that in as well.
Yeah, Teresa, that makes a lot of sense. Dr. Spinazzi, or either of you, is there a certain brand of probiotics that you feel would be a good one?
I don't have a specific recommendation. There are lots of foods that have probiotics in it, anything that's fermented. So depending on whatever cuisine you like, it could be kimchi, it could be miso, it could be kefir or yogurt with probiotics. It can be anything that's pickled or fermented. It can be kombucha, and these can be sources of probiotics through the food, or it can be an over-the-counter supplement, and I don't have a specific recommendation.
Do you see increased celiac disease in a dual diagnosis?
We are asking that question in this big research project right now. We do not have the answer at this point.
Okay. My daughter is a very picky eater, won't eat any veggies or fruits. Is that normal?
So picky eating is very, 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 very common. In all children, including children with Down syndrome, including children with a dual diagnosis. One mantra I have is you can't blame a kid for trying. So if kids are not natural fans of fruits and vegetables, then they're going to try to escape and evade eating fruits and vegetables. And it's how we respond to that might impact whether they do begin to try them or not. So if there's nothing else that's offered and they're still hungry, then they might end up eating it. If there's any sort of reward, whether it's a big high five or a star or whatever else, and that gets them to eat them, then that can be a positive reward system for eating one's vegetables. I think that the broader question is there a bigger sensory sensitivity around taste, flavor, texture that is underlying the extreme refusal of all fruits and vegetables? One can work with feeding therapists to overcome these sensory difficulties. There are programs at pediatric hospitals like Children's Hospital that can teach you things like food chaining and other behavioral techniques. There's a very intensive program called Clinic for Kids in the Bay Area that's a mix of sensory support and ABA-based support that can work very intensively on severe feeding difficulties. And then I always encourage thinking creatively about where veggies can go and hide in the form of smoothies, sauces, whatever else. As well as involving the kid in the fruits and the veggies whenever possible. So, you know, which one do you want? What are we gonna pick at the store together? And getting them involved in the cooking, getting them involved in the preparation, which could get you some buy-in. This can be a talk in and of itself. The pickiness around fruits and veggies is not in itself like a marker of autism, although certainly I see pretty extreme picky eating in kids with a dual diagnosis.
Yeah, let me also add, I totally get that. Nick is a big veggie eater, but fruits, no mas. So we, you know, probably go heavier on the veggies, but I will say, once he hit high school and they started doing cooking units, he really was open to trying new things. So that was really, really cool. You know, that his peers were making pancakes. He wouldn't touch a pancake forever. And then, you know, he did. And the other day I was making a salad and I was cutting tomatoes, and his salads never have tomatoes, but I had him sitting there. He took them and he just popped them in there. I'm like, who knew? So I think to your point, Dr. Spinazzi, if you just put it out there and then involve them in the cooking, I mean, that again gives them a feeling of more control as well, and it's a good independent living skill.
Thanks, Teresa. That is helpful. What tests would you recommend? Oh, I'm sorry. Well, we'll go ahead and go with that one, and then I've got a different question. What test would you recommend in a school setting? I'm not sure if that makes.
I guess this might be asking for a battery of tests to evaluate for autism in the school setting. And I would say, again, some sort of parent interview. Ideally, it would be something structured and measurable like the ADIR, and then the ADOS. And then one can have things like the social communication questionnaire, as other batteries of social functioning. The aberrant behavior checklist is a reasonable one. The BASC or the ADAS are other scales that are used to look at behavior and adaptive functioning. And then a Vineland or equivalent is often used, or a Welch scale to look at cognitive function and IQ, although there's a law in California that says that students who identify as African American cannot be evaluated in terms of their IQ because of historical discrimination and over-diagnosing of intellectual disability in African American students. So that might be missing from a battery of tests. I am a medical doctor and a primary care doctor who has developed a lot of knowledge around this topic, but I am not a psychologist, and I don't have a doctorate in psychologist, nor am I a school psychologist. So these are my recommendations based on a bunch of discussions and my interpretation of the literature, but I'm not the ultimate knowledge power around this. Another subgroup of the Down syndrome medical interest group that's working on autism research is developing recommendations around assessment norms. So I'm really hopeful that in the coming few years, we will have some more evidence-based recommendations for both schools as well as independent medical evaluations around this.
Thank you. My son has anxiety and OCD and gets frustrated very easily, has tantrums, but as a 19-year-old, it's about 5'8", it just looks like scary behavior to people that don't know him. Is this kind of behavior more of an autistic behavior?
So what it's so hard to answer this question without knowing more about your son. Certainly, when we are anxious and we can't necessarily communicate our anxiety, we can communicate it through our behavior and tantrum. And if someone is having more anxiety, more irritability, this like, what does OCD mean? Is it like a rigidity about their world? And there's significant communication impairment, then yes, perhaps there is an undiagnosed autism diagnosis there, but more would need to be known, in my opinion, before I can, I don't think there's autistic behaviors. There's just things that we can see in people with autism. And when there's a constellations of things together, then we think about autism and we evaluate. I just want to reframe this idea of from going to autistic behavior to patterns of behavior and communication and functioning that are seen in people with autism.
Yeah, I would also be curious if they're working with a behaviorist on the OCD component and supporting the individual, because I know what that looks like, because it can almost look like assault if you're going into a meltdown situation. I don't like to call it tantrum, it's more meltdown. There's a big difference. So that's certainly been my experience as well. But yeah, definitely we're finding a good psychiatrist and behaviorist that can give their anxieties up there, that's just going to amp up into to a meltdown.
We do have a question here, but we might require a little more clarification. It says, what kind of PT? Physical therapy.
I think that question may have come up as I was talking about what parents brought up as helpful interventions. They didn't specify, what kind of PT. I think that as that parent was answering the survey, they probably brought up physical therapy as something that had been helpful for their child. I think that the plan for every kid should be individualized. And so if someone has specific difficulties, maybe not even around strength, maybe it's around balance or feeling oriented in space, then PT could be helpful in that sense.
Next question. When my son was a baby, around 8 months or so, he had startle reflex, infantile spasm looking behaviors. We didn't know what they were or had never heard of IS before. When we brought it up to doctors and teachers, we were told it was probably sensory seeking due to Down syndrome. Eventually outgrew those startle behaviors, but then he had a big developmental regression around 3.5, 4, and was diagnosed with ASD when he just turned 5. Wondering if there is any need to see neurology at this point. He is 7 now, or if that ship has sailed.
Some people with infantile spasms go on to develop other types of seizures that can be equally subtle. They can be staring into space, they can be head drops, they can be other types of seizures that can be subtle. So if there is ongoing concern around whether a kid could still be having what they would be called subclinical seizures, right? Like not the kind of seizures you see in the movies, but rather seizures that are more subtle, then it might be worth seeing neurology. I think that an electroencephalogram, so lots of stickers around the brain, don't rule out a seizure disorder, but can be helpful in ruling one in. And of course, if there's ongoing seizures that are untreated, this could be impacting a child's development and brain functioning. So I think that a consultation with a neurologist could have some use, especially if you are seeing things that could be seizures. I don't think that by slapping an EEG on, they would be able to tell you if those startled things that you were seeing when the kid was young were IS or not. So I don't think it could give you answers about the past, but it could at least give you some information about whether there might be seizures still happening, and especially if there's any sort of abnormal movements that you are seeing. And then some neurologists do have some experience in autism care in general. And so if you are not connected with a provider who knows a bit about autism, this neurologist could also be a source of information in general.
Thank you. Teresa, this one's for you. My son is almost 6 with Down syndrome and ASD. Curious why you selected PECS versus sign language, struggling on whether we mainly go with one over another.
All the above. Total communication and sign language is a part of that. So I look at any kind of communication, whether it's a device or pictures or sign language, as a stairwell stairwell. So sometimes you can run down the stairs without holding on. Sometimes you need to grab on and need that support. So I highly recommend whatever works best for your child. Some kids are better with the low tech. I know when Nick was younger, when he was out in California, we had him tested for a higher tech. He would just take the little button, go, you know, put the needle on the record. And so we went low tech and just real pictures at the time, and then gradually increased to PECS. And then as he got older, he was more mature. We were able to get him to use the AAC higher tech device, and very effectively.
Thanks, Teresa. Dr. Spinazzi, can young adults be seen at Charlie's clinic or just children?
Our license only goes till 21, so we can only see people until 21. Don't get me started on how frustrated I am that there isn't an adult equivalent in our area. I know that Nancy and Marianne have been working hard for years to try and support the development of an adult program. The truth is that having Down syndrome programs is a fight every second of every day, because these are not hospital money makers. And so while I wish that we could be supporting adults as well, at this time, we can only see individuals until 21.
Thank you. Speaking of topics that we could spend an entire presentation on, I have 5-year-old twin boys with Down syndrome. One I suspect has a dual diagnosis, but it's unconfirmed at this point. Could you touch on the typical toilet training challenges that come with Down syndrome and/or a dual diagnosis, and just a few tips on the different strategies?
That would be me. Okay, so can you repeat the first part of that question? I was typing in a resource on the.
Sure. 5-year-old twin boys with Down syndrome. One suspected dual diagnosis, but it's unconfirmed. Can you touch on typical toilet training challenges that come with Down syndrome and/or dual diagnosis, and just a few tips on different strategies?
Sure. In general, the toileting process, or training, if you will probably be delayed because you've got the characteristics of low muscle tone related to Down syndrome. Now, with the dual diagnosis, it's probably going to be pushed back further, maybe more for sensory reasons, understanding. Certainly for my son, I speak quite candidly about the whole toileting adventure in my book, but his signs of readiness weren't there like my older son, who's and so basically we tried getting him, you know, at the normal age you would try, and nothing was happening. It took a long time, and it actually took mostly getting him into a habit training schedule, and that takes a lot of discipline for you as a parent, but I guarantee you it will work. And probably one of the proudest things I've done is to get my son in boxer brief underwear. It's like, you know, not easy, but it can be done. And I will say that the Down Syndrome Connection Bay Area is planning a toileting workshop this year.
Yes, that's a common question.
I just want to highlight how when we talk about toilet training in kids with Down syndrome in general, we're talking about supporting, communicating the need for using the toilet, rewarding the sitting on the toilet, and as well as just a little bit of schedule, like time, like training on a schedule, because especially initially, it helps if you're bringing the kid to the toilet at the time when they actually have to go, as opposed to missing it because you don't necessarily know when the kid is going. So there is a toilet training resource on our Charlie's Clinic website from the NDSS. And then the piece that I think is difficult in kids with a dual diagnosis is that, again, this idea of, I don't necessarily, like, it's not obvious to me that I have to communicate that I have to use the toilet. And it's the reward, the inherent reward of my mommy is proud of me for going isn't quite as rewarding because of this autism piece having a little bit of like the immediate social reward isn't as rewarding kind of thing. Plus the difficulties with the receptive language, plus the sensory, and like this idea of, I've been going in the diaper the whole time, like it's working just fine for me. I don't have a motivation to do it any other way. And so I have also found that training on a schedule can be incredibly effective. And then the other piece being, use that ABA. Once ABA comes into your world, make sure that toilet training is one of the goals. And make sure that the school is doing it too.
100%.
Okay, and looks like here's one. My daughter is due for school re-eval. At the last eval, they disagreed with her clinical ASD diagnosis. They have recommended ABAS for her. Is this something like Vinland or more appropriate for a child with DS-ASD?
The ABAS is another measure of adaptive functioning. And I think that so you can disagree with a school evaluation. So you can, again, request an autism evaluation as a part of your triennials. And then if they deny it, you say, I want to go through due process and go through the motions of that denials. And if they do it and they say there's no autism, you can always request an IEE, an independent evaluation, which will be at the district's expense, and and you can find potential evaluators that are independent of the district and can do that evaluation. One thing that I have found is that in this weird time of COVID, schools have been a little bit more open to accepting outside evaluations, because obviously they're not doing enough of them on site because the schools have been closed. So this may actually be an opportunity to bring forth an outside evaluation and really insist on it being accepted. You don't have to sign it if the autism diagnosis is not on it. You can say, no, I disagree with this. I want to go through due process. This is very meaningful for my child's life, and I want this on the IEP. And I think I think that part of it, having gone to a lot of IEP meetings, it's so intimidating when there's all of these people who are educational experts that are around the table that are telling you that you don't know what you're talking about. And it makes me so mad when this happens, because obviously you as the parent are the expert on the child and you know what you're talking about. And I think that part of it is kind of knowing in your mind, in your heart, and in your gut that you know you're right, that you know that your kid has an additional diagnosis. Hopefully with these talks, there's also more of an awareness of all of the reasons for having this diagnosis be recognized and called out in the IEP. I can't tell you how many times I'm told, well, it won't matter, the IEP is the same, it's the same services. Well, actually the district gets different funding if there's an autism diagnosis, and regardless, it's a different way of understanding the kid, and you have a say over the eligibility criteria. Can you hear my rage? just
I totally agree, and that was our experience. And a lot of it was, you know, that requires the school district to fork out more money for those services. So of course they're going to say, well, we can operate on this diagnosis just of Down syndrome. Well, no, this is a whole different ball game we're in with this dual diagnosis. And in my experience working with parents and personally, now I'm going to get all fired up, is that the autism supersedes Down syndrome by, I mean, it just trumps it. And that's what you've got to focus on, that piece. It's, yeah, and that's all these things, all these interventions you can add, the behavior, helping them get their voice, get their sensory needs met, all come together and really elevate what the potential for your child, for sure.
Dr. Spinazzi, can you provide the information of the webinar you mentioned you'll be holding in March? This participant did not get whether that webinar is a part of this series or not.
It's not, but it's still from the Down Syndrome Connection. So you're going to get information about it as soon as we've made the flyer. We've been organizing over the past week and a half.
And kind of to just piggyback on that, we had a couple more requests as far as sending out links and information to all who registered for this webinar. I don't know if we're emailing individuals separately or if we're just going to have that information in a centralized location. For example, on our Down syndrome autism page on our website. I know that Dr. Spinazzi, you had mentioned that you would share this recording, and that's something that we can post on our website, and then everyone will have access to this recording. Hopefully that.
Can I just share my screen for the quickest of seconds? Because I know that you will put the links to the right things on your website. Our website is www.charliesclinic.org. And when you log on, it looks like this. And then if you go to development right here, there's a section on autism. And there's a little menu here. And then this is a little care map kind of thingy that I actually made as I was talking to Teresa, and we were talking together about different pieces of autism care, and I'm a visual person, so this is kind of a little visual. And then this links you to other pages on our website that have to do with things like sign language and total communication, for example. So you click on this and it takes you to the correct resources, and guess what? A lot of it links you to Down Syndrome Connection resources, because the Down Syndrome Connection of the Bay Area is amazing. See, it links you to the page on the Down Syndrome Connection website. And then there is information for how to get a consultation through the Down Syndrome Connection of the Bay Area with Teresa. There's a link to the DS-ASD Connection. There's information from Down Syndrome Education International. as well as NDSS. And then the recommendations for providers, which you can print out and bring to your doctor if you're going to discuss concerns around the dual diagnosis, as well as recommendations for caregivers. And then Teresa's blog, because I believe that parents know a lot more than any provider because they've lived through it. And I'm constantly adding stuff. And so you can find a lot of stuff here. And then under trainings and events, more medical version of this exact presentation was presented at our hospital's grand round. So under books and trainings and events, there are all of the presentations that I have given, including one on puberty, since puberty is a hot topic, but you can go here and the password is here, and then this presentation, it's a little bit more medicalese, but it's the same stuff, and you can access it here. So definitely Down Syndrome Connection can put stuff on your website. Sharing is caring, says Barney, but charliesclinic.org, it's all there.
Thank you very much. And one person did just mention it would be helpful to have the slide deck so we can maybe coordinate with you to possibly get a PDF that we can post with the recording.
So the reason that I can't do the slide deck quite yet is that the publication of some of this research is still in process. So I want to share the slide deck and I can't right now because this information needs to reach a big audience around the country and the world. And until that's published, I can't share stuff that has like percentages and stuff like that in a PDF form. As soon as that's done, you will have the PDF for the slides. And I apologize that I cannot do it right now.
Thank you for that clarification. But again, for all of those of you who are interested in revisiting some of the content we discussed today, will have access to that recording, which of course has the presentation and those slides. It might be a little bit more time consuming to navigate, but at least the content will be there and available for you on both of those websites. So with that, I don't think we have any other questions for you all. I'm going to go ahead and show my face here. There we go. I just wanted to thank you both for joining us today. And I want to thank all of our participants for putting in a little extra time with us. I think that it was well worth it because we all learned a lot, got a lot of information. And I think this has been a great start to this series. And I look forward to learning more and more about the dual diagnosis of Down syndrome and autism. And we do hope that you all join us for the next series next month, next piece of the series next month. But thank you guys for joining us. Thank you, Dr. Spinazzi. Thank you, Teresa Unnerstall. Thank you all. Have a wonderful weekend, and we look forward to seeing you next time.